the needle actually doesn't go into the rectum, so we completely reduce the risk of infection, which makes the procedure safer. And also we don't have to move the probe around inside the rectum so much, so it's a lot more comfortable.
We've got a group that we formed ourselves, amongst ourselves in Gisborne, because there was no other type of group for men's prostrate. We've lost three men in there, you know, through that time. People in the rural area of Tairāwhiti, they're living in, in farms and back blocks. There's no access to GPs, let alone hospitals. And if they do get sick, they're meant to be tough. So, so if there's a first initial signs, they'll just brush it away.
Prostate cancer is the most diagnosed cancer in New Zealand, and Maori men are particularly vulnerable. I'm here this week on the Eastern Cape of New Zealand in a little town of Gisborne, where half the population is Maori. And I'm here to film with a wonderful gentleman called Dr. Cornfeld, who's leading an innovative study to improve and personalise prostate cancer diagnosis, with the ultimate goal of catching the cancer earlier for better patient outcomes. Dr. Cornfeld, I've been told, is just in the office here. Here's his name. Dr. Cornfeld.
Hello.
How you doing?
Thanks for coming.
Great to meet you. Great to meet you. How is it? I will do. Thank you very much. I guess we should start by just explaining what the prostate is, what it does, and what challenges you've historically faced when it comes to addressing cancer in the prostate.
Okay, so the prostate is a small organ in men. It sits at the base of the bladder. It surrounds the proximal part of the urethra and sits between the bladder and the base of the penis. As far as for its function, it doesn't really do all that much. It creates some lubricant for intercourse. The semen goes from the testicles to the ejaculate through the prostate. Those are kind of its major functions.
So Dan, this is this 65-year-old male has been referred by his general practitioner with an elevated prostate blood test of 14 and a hard nodule in the prostate gland on the right side.
Traditionally, diagnosis of prostate cancer has been really difficult. That's a small organ, and unless the prostate gets really, really large and starts squeezing on the urethra or impinging on the base of the bladder, which most commonly happens not due to cancer, you don't have any symptoms from something abnormal growing in your prostate.
Just over here is the prostate cancer men's support group that Dr. Daniel Cornfeld attends. And I've come over to meet some wonderful gentlemen who are going to talk to me about their journey with prostate cancer, and in particular, a man called Mātai Dani Patawai, who's going to give me a little bit more on a personal level about his experiences. Dan, lovely to meet you. So at 65 years old, you go for your test, the PSA comes back high. How did that manifest itself symptoms-wise?
For me, there's no symptom whatsoever. There's no way of knowing. I since found out that when mine hit 12, it had already metastasised by then.
So Dr. Dan, why the reticence from Maori men to come in and get a screening?
Okay, so that's a very good question, and a question that we don't know the answer to. So the traditional screening tests for prostate cancer are a digital rectal exam from your physician, where your physician will put their finger up into the rectum and try to palpate the prostate. So this is the prostate here, sitting at the base of the bladder, and we'll show later this is an ultrasound probe up in the rectum, but on a digital exam you can put your finger up and try to feel the back of the prostate. And if there's a hard cancer in the back of the gland, you can feel that with your fingers. Now that test only feels the cancers that are at the back of the gland. It's going to miss any ones on the sides or at the front. It's only going to be the part you can feel with your finger. The second screening method is a blood test called a PSA test.
The thing I remember is the digital was the worst out of anything. Because right at the very beginning, you don't know what to expect. And you're with your GP who you've been with for a while. And then he just says, jump up there, and it happens. You didn't expect that. When you go through this procedure, I think you have a responsibility to share your knowledge to your fellow man. So for me, it's my cousins, my brothers, workmates. You help your fellow man by putting the word out there.
So in the past, patients wouldn't have imaging after a positive PSA screening test. Then when they went to biopsy, ultrasound would be used to guide needles into the prostate, but not into a specific target in the prostate. This picture is a graphic of a prostate with a tumor within it. So some of the biopsies may go through the tumor, some of them don't go through the tumor. But you can imagine a case where none of the biopsies go through the tumor, and even though there's disease in the prostate, the biopsy doesn't detect it. So the outcome of this process is that sometimes you miss the cancers that are there. Even when you detect the cancers that are there, you don't know their size, their shape, or their histology. And that's not a reliable process. Historically, you didn't get an MRI before you got the biopsy. And I think the first step towards improving the diagnostic pathway is getting an MRI after a positive screening test. And then there are people who can cognitively use ultrasound to target that based on what they saw on the MRI. I think the next step to improve things even better is to use one of these systems that actually fuses the images, so that when you're doing the ultrasound and you're doing the biopsy, you're actually visually targeting the lesions that you identified on the MRI. And I think those two steps together will really improve the yield of prostate cancer screening.